We begin day 3 with a keynote session, where we'll challenge assumptions, spotlight innovation, and revisit key takeaways from recent congresses. Joining me on the panel today are Roxana, Mehran, Holger, Thiele, and Nicolas van Mieghem. And we're really honored to kick off with a keynote from a leader in the field, Dr. Mike Gibson, who needs no introduction. He's certainly on a personal level is a friend and a mentor, but has wide-ranging appeal, and I'm super interested to hear him talk about a topic that's rapidly transforming medicine, the future of digital health, AI, and trials of the future. With that, we'll kick it over to Mike. Really interested to hear what you have to say today.
Well, Ajay, thank you, and great to be on a panel with you and Roxana, Holger, and Nicolas. It's so great to be with all of you. The world has changed. Patients are more empowered. We have a lot of tools at their disposal now. Used to be Dr. Google. Now they have ChatGPT, which has also leveled the playing field. So how do we embrace this change? How do we continue to empower patients, put them at the center of trials, bring trials to them rather than them coming to the trial, and also do things less expensively? We just can't spend hundreds of millions to billions of dollars every time we want to make an advance. So that's what I'm going to try and address today in this keynote lecture. I will be talking about a trial that I'm leading, which is funded by Apple and J&J, for full disclosure. The pandemic taught us a lot. We must be able to do studies and trials that change the way we do things inexpensively. And what if we could do a trial that used to cost billions for 1% of the usual cost? That's what I'm going to talk about today. We feel the need for speed, to quote Top Gun. Think of the pandemic. We had to come up with solutions very, very quickly. So we need speed, but we also need to do it preserving quality. Quality really is job number one. It should be at the top of the list. So patients are out there wondering, is this real? Do I really need to take a vaccine? What is the quality of the work that's been done? So we've learned a lot, and I think we're moving towards a new paradigm in executing clinical trials. There's a lot of ways we can, reach these goals. We can cut down on monitoring. That's 40% of the cost. We can use registries as the backbone of doing these studies, which I think is very good. Sweden does it well. The UK does it well. Brazil has 250 million people in their healthcare system. They can do it well. We need to reuse electronic case report forms. We have better statistical techniques. But one thing I want to talk about are virtual trials, where we get rid of all the bricks and mortar and conduct trials with about 1% of the usual cost. If we can do that, we can have many more shots on goal in the healthcare sector. Many of us grew up in the days of single-center trials back in the original atherectomy studies that we did at the BI. We did that. Then we had multi-center trials, mega trials. Now we're doing what I would call giga trials. Trials not at 10,000 patients, but at 10 to 100,000 patients. And that's what I'm calling a giga trial. And it's powered by wearables and patient engagement. I'm leading a trial called HeartMind. This is a virtual trial, a direct to participant trial. It's not a patient because they don't have the disease yet. And that's another change. It's decentralized, it's randomized, and it's real world and pragmatic. So we randomized about 34,000 people to an Apple Watch or not to detect if we could see atrial fibrillation in people who were asymptomatic. Here's the kicker. We had to approach 350 million people to get there. So it's a big challenge in doing a direct to participant approach. The design is shown here. I'm not going to go through all the details. Basically, people were randomized to an Apple Watch or not. And then we're using a claims database to see, did they in fact detect atrial fibrillation with the Apple Watch in a clinically meaningful way? Engaging patients can be challenging. We talk about education. I call it engage-ucation now. We must be engaging to educate. We were really worried about engagement because you can see some pretty low rates of patient engagement in other studies. But we were dumbfounded that 87 to 90% of time over the course of 2 years, we had engagement by these patients filling out electronic patient-reported outcomes. They told us about depression, anxiety, sleep, eating, exercise, a whole host of things outside of the primary question. And that allows us to look at the intersection of, say, sleep and atrial fibrillation, anxiety, depression, all of these other allied health conditions. How are they related to the primary endpoint? But the main finding is the ability to engage people 90% of the time. How did we do that? We did it with engaging programs. We provided them with credible medical news every few weeks. We also gave them points for their participation that they could redeem. So engagement is going to be critical in these efforts. How can we lower cost? Again, we want to get the cost down to about 1% of the usual cost. I think in the old world, it was hospital-based, paper-based. There were electronic case report forms that the nurse filled out. In the New World Order, we'll be doing virtual trials or hybrid models. They'll be enrolled by an app online, only one IRB, only one consent process that's done electronically. They'll be followed up online by apps, and then we'll use claims databases to see if they had hard outcomes, and that's much less expensive. I think these numbers on the left are outdated. I think we're up to about $250,000 per patient in the oncology world. We spent $4 billion on one study that I'm involved with now. We must reduce those costs. It costs $80,000 now to track down a patient, and 40% of the cost is spent on monitoring. In the New World Order, we were able to get things done at 1% to 2% of the cost. We have no missingness because everyone's in the claims database, and we don't have monitoring, which automatically drops the cost 40%. In the old world, Ajay, Roxana, all of us would sit around and adjudicate events over some pizza and Diet Coke. But in the new world, we'll be using just the claims database to get this job done much less expensively. Does that work? Does the outcome using a claims database match what we would get if we were using a CEC? And the answer is, overall, for the results as a whole, the numbers are nearly identical. And this is something that Bobby A. and I and others have published multiple times now here, showing that we can rely on a claims database to get us to the right answer. In the past, you had paper source documents. There was a lot of verification of checking if what was on the paper was what was on the electronic case report form. I think in the New World Order, we need to focus more on fraud detection, and there are tools to do this. We did find, say, in one site, it was the same exact EKG used for 15 patients. Now, if you send a monitor out, every single one of those patients, it would have made sense. Oh, yes, here's the EKG. It matches what's in the computer. But no, there still can be fraud. And I think we have better tools to detect it without expending all those human resources. How can we do things more quickly? We always sit around and say, well, what do you think? Is it going to be 0.3, 0.5, 1 patient per site per month? But imagine a paradigm where you're able to enroll 50,000 patients per month, as was done in the original Apple Heart study. A tremendous game changer. Now, how do we do recruitment? In the old days, the nurse, resident physician would find the patients in the clinic or in the hospital, but we used social media, Facebook ads, influencers online. I did a lot of TV interviews, both local and national, but the biggest thing was email campaigns, and we did a lot of A versus B testing. What's the right kind of message in the subject line? What's the right kind of colors? Here's the crazy thing. It was an orange background with white letters. Who would have thought? So we learned a lot about how to do this. We could also dig in and prospectively identify patients through their electronic health records. But as I always say, once you've seen one epic, you've seen one epic, and it can be very costly to dig into those and confusing. Consent. In the old world, it was paper-based, institutional specific. You had a local IRB. But in the New World Order, it's electronic. You have a great communicator talking about the risks and the potential benefits or lack thereof. And you use a central IRB. One IRB, one process, and can be used internationally. What can we do to improve quality? I think we're getting more and more sophisticated statistical tools. I think we're, learning to balance accuracy versus biases. I think we need to reduce bias, perhaps with a little less accuracy with the electronic medical records and claims databases. We want to be able to reduce missingness. And with the process I'm talking about here, with a claims database, no one goes missing. And by using broader groups of patients, we'll have greater generalizability of the results. Finally, when you have enormous amounts of data, you have the enormous potential to use AI and machine learning to make a prediction for any one patient. Trials usually tell us about population results. We want to drive to individual patient type results. Monitoring, in the old world, you said there was an AE, it would take months for it to get adjudicated. Then there'd have to be programming for the DSMB, always very delayed. We're trying to speed things up with the claims database to get things done more in real time. And that way we can identify adverse events almost in real time. We always sat around and said, oh my gosh, are we going to have enough patients to answer the primary question? But here, when you have 34,000 patients, you'll be very well powered and you'll really be able to definitively test the primary hypothesis and probably have enough patients to really look meaningfully at a lot of secondary hypotheses. I've already mentioned the need to reduce and eliminate missingness. In the New World Order, we aren't going to have to pay $50,000 to $80,000 to find the patient. They will be there in the claims database. What's the future look like? I think we will have more generalizable results with larger patient populations. I think we'll be doing more real-world studies in broad numbers of people. That's a big part of the future. But one of the things I'm most excited about is taking AI and machine language to harness all of those pieces of data that we have. So when you have 34,000 patients, each with terabytes of data, when you have many petabytes of data, that allows you to deploy AI and machine learning in some powerful ways. Rather than just look at the prediction for a population, patients want to know, what about me? I don't care about the whole population. What does this trial mean to me? And can we tailor every kind of decision, like the dose, for that individual patient? I want to give you a preview of something that we've been working on for a few years now, using AI to make individual predictions. We use Bayesian analytics, not to just give us a point estimate, but to give the patient a kind of confidence interval. Your risk could be this low or this high. So we're giving people the standard deviation or the confidence interval around the prediction. That's something new. Rather than just make a prediction about outcomes at the beginning of the study, we iteratively assess risk just like a doctor does. You come back to your doctor, they reassess your risk. We reassess risk every few months. So an assessment that's iteratively done, just like what your doctor does. We count multiple events because people want to know about the burden of their disease. And then, very importantly, we're using utility scores. So not how a population views bleeding versus ischemia, but how do you, Roxana Mehran, how do you, Ajay Kirtane, how do you order these variables? Like, is death a 1 for you, a stroke that's disabling a 0.95, a non-disabling stroke a 0.85, an MI a 0.5, a bleed that's minor or 0.2. How do you, as an individual patient, order those outcomes? And then we tell you what's the right dose of your drug to maximize what you want in terms of your outcomes. Over here, this shows the journey because people have multiple events and they follow different trajectories for those events, and the risk changes over time. So this is what it's going to look like on an app for kind of shared decision making. You can see that the patient ranks their preferences, and then you show them what's the total score for a given dose, say 15 milligrams of edoxaban, 30 milligrams, or 60 milligrams. Well, here it looks like 30 milligrams optimized this patient's desired outcomes. So it can be used for shared decision making and really driven by that patient's preferences for bleeding versus ischemia. In terms of follow-up, I also want to bring to your attention, we need not just 3, 4, 5 years of follow-up, but the FDA really wants to know what has happened to that patient over 20 years after their valve implant. We've now built a registry that will follow patients in device studies and drug studies for 20 years. We are working closely with the ACC to deploy this as the long-term follow-up for the NCDR registry, and we're working with the FDA to deploy this in a variety of studies. So when you get randomized, you'll also be signing up for long-term follow-up. You can hit the blue button and have CMS, access to your CMS claims database so we can track what's happened to you. We'll also be contacting the patients by text and email to see, did you have a recurrent event? Did you have a recurrent procedure? Did you have a stroke? Did you have a bleed? So that way, in a very simple way, we can know iteratively over time what happened to patients over the long haul. So to wrap up and summarize, we're moving from bricks and mortar to a virtual world. The outcomes aren't going to be on case report forms. They're going to be in insurance claims databases. The consent's not going to be local. It's going to be international. The sample size will move to tens of thousands of patients in pharma trials, but maybe hopefully larger in scale for device studies as well. The representativeness will be more real world and more generalizable. We'll be able to enroll tens of thousands of patients per month. The way we reach patients is going to change. It's going to be through social media, TV, radio, and email. We're going to need to do trials in the future at a fraction of the current cost. We're going to reimburse patients for their effort, and we're really going to move to using all the information that's out there in a claims database. And I'm very excited by countries like Brazil, 250 million people in their claims databases. You don't have to be over 65. Everyone's in there, and we can do studies very, very quickly and easily in some countries that are very well organized in this fashion. So I think I covered the summary, and I want to thank you, Ajay, and I want to thank Roxana and Holger and Nicolas for inviting me today. Thanks, everybody.
Mike, that was phenomenal. And I have to say that due to my personal familiarity and friendship with you, I was remiss and didn't give you the proper introduction that you deserved. I was thinking about that the entire time you were speaking. And frankly, it's incredible what you sort of present to us because it's very disruptive, but it comes from a background of long, hard work and experience in the world of clinical trials that we kind of grew up with. And I think many people have been inspired by you looking at, how things have gone with all the clinical trials you've done, but the recognition that there are limitations to what we can accomplish with those trials in so many ways, as you so eloquently expressed, is what I think, encourages you to look for disruptive solutions. I remember at the ACC, I asked you, hey, how much longer are you going to keep doing this? And when seeing this talk and seeing what you're inspired by, you want to keep doing this because this is the way to transition everything we learned from those trials into the future. So thank you so much, Mike, for that phenomenal talk and summary. I think it is a lot to talk and a lot to talk about amongst us. So let's just start really quick. I have the question from the audience who sort of asks, what does this mean for clinical practice? Does it mean more data, faster data, faster, better guideline updates. Maybe I'll start first with Nicolas. What do you think about this? This isn't US specific. This is actually generalizable across the world.
Well, that would be my major concern here. How generalizable is it? Because central stage is the claims databases, but claims databases are national by definition. So how do you generalize what is the studies that are run in Sweden or in the United States or in South Korea or in Brazil to what's happening in other countries all over the world? Because the claims databases are so different and they're not capturing the same information, and probably the quality will not be the same in all countries. What's the
Mike? I'll give that back to you to answer that, because I know, Mike, you figured this one out.
Well, no, we haven't figured it out. We're building the plane while we're flying it. There will be some countries where it will be very easy, like the UK, Sweden, Brazil, and then there will be challenges in other countries. I don't expect all of this to be done necessarily in phase 3. I think in phase 3, where you need a lot of lab values and things like that, a lot of in-person visits, you're still going to stick with the traditional model. What I think you will see is a hybridization, where you have some of these techniques to build, add on to make it less expensively. But I will say we have identified echo centers around the world that go into a patient's home to get the echo. We now can go get blood in the home. Now for the outcomes, in the Oxford group just says, "Did you have a heart attack, Mr. Jones?" And Mr. Jones just clicks, "Yes, I had a heart attack." They don't verify it, but they don't really use, the source documents from the hospital record. We're relying on patient-reported outcomes. Now, you might say that's not accurate, but it's not biased. And, once you enroll tens of thousands of patients, the accuracy probably is overcome by the extent of the data. So big challenge. You're right to point it out, Nicolas and everybody, but I think we're going to work on solutions for that.
So Roxana, maybe I'll have your general comments, but maybe ask you a specific question as well that you can address if you want to. But we recently saw at the ACC, you may cover the trial of the Sentinel device, and in that trial, exactly as Mike said, it was a questionnaire that ascertained stroke. So is that something that we can expect when we're looking for device efficacy? And maybe just some general thoughts about the paradigm that Mike has brought up.
Yeah, I mean, I think I'm sort of, I don't know how to answer this, because part of me wants to believe that we could collect data, and I believe that we will get there in a way that we'll be able to get to where Mike wants to go. But where we are today, every time I see a pragmatic trial, I see a neutral effect, almost always. And I often imagine, is it because they just didn't do the kind of due diligence that we are used to, going in there, looking, adjudicating, blinding all of the adjudication forms and going after the events and tracking down every patient and doing all of that. I think we're sort of in the middle of kind of getting away from the very, very difficult, intricate, detailed work that we did with high costs and where Mike wants us to go. And we will get to where Mike wants us to go. I'm convinced of that, but I don't believe we are there yet. And I think what Mike is doing is trying this out in one country where he believes it's going to be a good place to kind of beta test, if you will, before you go worldwide. And I think that is a very, very good, in good measures. But I hate to say it, pragmatic trials, show me one that is positive, that actually showed what we believed, or maybe we were wrong. Maybe we are drinking the Kool-Aid. Maybe the pragmatic trial and everything is neutral and nothing matters. But I hate to think that way. I imagine that we would make progress.
Let me just say,
well, one thing that's interesting is if you get to let's go ahead. Mike, just 1 second. Let me just make one quick point. But one thing that's interesting is that it also gets to, what the real world is in terms of implementation, because you might have a super effective therapy, but that when you implement it in the real world, it takes years to actually get uptake of it for a variety of reasons. And so the pragmatic trial may be some representation of the truth of implementation as opposed to the actual efficacy of the thing you're studying. But Mike, what were you going to say? Sorry to interrupt you there.
Well, on the pragmatic trial front, I mean, we do trials of, 10 to 20,000 patients to show something works. You need that many patients to get that p-value to show statistical significance. Then someone comes along and does a 1,000 patient trial of some heart failure medicine and said, oh, it didn't work. It didn't improve outcomes when we did it in the real world. Well, you were grossly, grossly underpowered. So I don't think that's the way implementation science trials should work. They should really focus on, did you implement the strategy which we've documented works, and I think you're seeing a lot of trials that are underpowered. The way we are working to validate this is, as part of the registry I built, we describe definitions of the outcomes at 6th grade level. Okay, so here's what a heart attack is as distinguished from having a cardiac arrest. And we write that at 6th grade level. We're going to compare the responses that the patients make to what was in the CMS database. So we'll be able to see how good are patients at saying I had a heart attack, a stroke, rehospitalization versus what was put into the CMS database. That way we'll have a check on, as all of you are saying, oh my God, is this accurate? That way we'll have a check on the representativeness and accuracy of these responses. So you're right, that's a big challenge, but we're going to test it out.
That's I think a great point. And again, Mike, it's reassuring to have somebody who's talking about disruptive things grounded in the history of good clinical trial design. And as you said, is the implementation actually occurring, et cetera? Because you could imagine that if you don't have that background, this all looks really cool, but you don't know what could happen with it. Holger, what are your thoughts on this? I mean, you've run a lot of clinical trials. You've run them across Germany and even including other geographies too. So what are your thoughts on this? Is this something that you feel, what would it take for you to feel confident enough to employ these types of designs in the trials that you make?
Yeah, first of all, I loved your talk, Mike. It's a vision into the future. Honestly, I'm a little bit skeptic that we can implement this in the nearer future. So I only overlook what we are doing in Europe, what we are doing in particular in Germany, in particular regarding data privacy policy. So it's so difficult to get data. And it's nearly impossible often. And also the interpretation of data, getting data from patients. This is so complicated. Each hospital is doing it differently. Each ethical committee has different requirements for this. At least this is what we are fighting with every day. I can only imagine what we have done in culture shock. So each ethical committee in each country had different requirements to do such a trial. And if we could overcome this, I'm sure we will overcome this, but this will take probably another 5 to 10 years. Maybe you have your view from the US side. At least what I see in Germany and also in Europe, the data privacy policies are much more strict in comparison to the US. And that's the reason why I love your vision, but I'm not sure if we can really overcome this in the next time.
So Mike, how do you respond to that? I think there's some concerns, but there's certain geographies actually that have really figured this out, and they're so much more efficient. I think everybody points to Sweden as an example of this in the clinical trial space. I mean, they were able to do pragmatic trials, quick trials, thrombectomy, whether it's pharmacology, et cetera. So Mike, what do you think?
Well, they really are the model. And you notice I fly a lot to Brazil. I'm down there a lot these days because they have 250 million people. It's like Sweden on steroids where we could do this. They also have tremendous genetic heterogeneity. They have a lot of Black people who will participate in trials. They have the world's largest Japanese community outside of Japan. So different countries may get this right sooner. I have mixed views on the privacy issue. I really am a privacy freak. I want my privacy. I get it. but it's really hurting our traditional trials as well. When someone drops out of one of our traditional trials, we can't go and even approach them or let alone get any of their information. So the privacy laws may have gone a little too, in my mind, have gone a little too far right now. And I'm hoping the pendulum will swing back for all of us to be able to at least approach people to find out what happened to them. But Holger, you raise very real questions about the ability to execute. I think it will take a lot of time. We may not be able to execute all of this, but I think we can take bits and pieces that work well to improve our efficiency.
No, I think that's great, Mike. Any other final comments from the panel? Because I know we want to definitely get to a recap of ACC, because that's also really relevant to this audience. I just reflecting on this, think that the costs are, to emphasize the points Mike made, the costs are getting out of control. And one thing that I personally have interest in and experience with is, on the renal denervation trials that we led, what we found is that patients were referred like 10 to 1 through self-referral using Facebook groups and things like that, as opposed to, coming through their referring physicians. In fact, when the therapy's actually been implemented in practice, very frequently we hear from our physicians, but we very frequently hear from patients themselves who've looked at this and figured this out. And there's definitely a missing link there. I think that many patients around the world are looking to other sources of information, not in a way that we as physicians think of them pejoratively as Dr. Google, but they're really looking for information because there has to be a better way to get them engaged. And the same thing is true with clinical trials. And I think that if we want to continue to uphold science, we have to reach patients where they're at as opposed to where they think they ought to be. That would just be my editorial summary of some of this. And Mike, I hope you agree with me. I'll give you the last word, Mike, to summarize. And once again, thanks so much for this amazing keynote.
Well, we have pivoted over to patient-centric care, Ajay. There are numerous really well-organized communities for rare diseases, but not for cardiovascular disease. So right now, I'm spending a big chunk of my time trying to build communities. We have 4 million people in a community called Stuff That Works, that I'm partnering with the founder of Ways. There you go to the community, to the 400,000 patients with self-described obesity, and you say, here's a trial for you. So I do think, Ajay, you're right. That's where we're going to find patients in the future, is in these organized communities. That's where they're getting a lot of their information. So you hit the nail on the head. It's all about communities. And look, they're going to go to a telehealth provider to get their GLP-1. They're not going to come to their doctor in the future. It's a model of how patients are really working around the bricks and mortar. We can either skate to where the puck's going to be or be stuck back in the 90s. Let's try and skate to the future.
Well, thanks again, Mike. Really fantastic and a lot of food for thought. We're going to move on now to the next talk, where Dr. Mehran is going to shed light on some of the key highlights from ACC 25, which we are still processing, having come back from the meeting. Take it away, Roxana.
Thank you, Ajay and Mike, for that wonderful talk. Let me just begin by saying that what I will do in the next 20 minutes has nothing to do with what these trialists did for 10 years or more to actually get each of these trials up and running, funded, patients enrolled, results evaluated. So I'm doing no justice because it's a couple of slides per study. So before I start, it's important for you guys to note my disclosures. And let's move in. I divided this into the pharmacotherapy, and in many ways for us as interventional cardiologists, I really focused a lot on those trials where I believe we're going towards from intervention to prevention. And then, of course, on coronary and structural interventions, great stuff to talk about. So let's begin with pharmacology. The STRIDE trial. Everyone knows about GLP-1 receptor agonists, and semaglutide being the one that is most often used, with fantastic studies that have come out. And this one was on patients with peripheral arterial disease, symptomatic peripheral arterial disease and diabetes, in a double-blind placebo-controlled fashion, Dr. Banaka and colleagues published in The Lancet showed us these 792 patients who were randomized one-to-one to semaglutide versus placebo, with visits very, very often up to 57 weeks, with a primary endpoint of ratio of baseline to maximum walking distance at week 52 by the constant load treadmill. And they did a confirmatory secondary endpoint with minimal mean walking distance at 57 weeks. And what you see here is the primary outcomes, tremendous improvement in that walking distance, 40 meters, the mean difference being 40 meters, which is tremendous for these patients with chronic patient diabetes. So another great outcome for these trials. These drugs, semaglutide, of course, is an intra subcutaneous injection for most, but here oral semaglutide showing for type 2 diabetic patients and atherosclerotic disease and or CKD. 10,000 patients presented by Dr. Darren McGuire and colleagues, the SOUL trial, showing major adverse cardiovascular disease decrease of 14% reduction, 0.86, exactly like what we saw in SELECT and others. And that was with subcutaneous semaglutide. Cardiovascular death, similar, but you see all the trends in non-fatal myocardial infarction, major adverse limb events, kidney events, similar, but non-fatal stroke also did not meet statistical significance, but you see the important outcomes pretty much all in favor of oral semaglutide, which gives opportunity for oral semaglutide to come up. In transcatheter aortic valve implantation, we see the work with the colleagues presenting this important study in patients after transcatheter aortic valve implantation, patients who came in with aortic stenosis but had some heart failure as they came in. Prior heart failure admissions were the ones who were included, LV ejection fraction of less than 40%, or diabetes, or estimated GFR of being between 25 to 75 cc's per minute. Patients were randomized, 1,257 of them, to dapagliflozin versus control and followed over a year. The ITT analysis shows a tremendous benefit with the use of dapagliflozin in these patients in reducing death from any causes and worsening heart failure. Most of it driven by worsening heart failure. As you could see, there was a price with genitourinary genital infections, as well as some hypotension. The next trial I want to talk about is dual antiplatelet therapies. And this is really interesting. Our colleagues in Korea, the host bleeding risk clinical trial, host BR clinical trial, all according to bleeding risk. Either you're at high bleeding risk or at low bleeding risk. These investigators did two different strata. The high bleeding risk patients received only 1 month of DAPT versus 3 months of DAPT, followed by a single antiplatelet therapy. The low bleeding risk patients received 3 months versus 12 months of DAPT. And they looked at NACE, MACE, and bleeding. So let's look at the high bleeding risk patients. In the high bleeding risk patients, 3 months was associated, 3 months, not 1 month, but 3 months was associated with an improvement in 1 year net adverse cardiovascular events compared to 1 month, because there was a reduction in MACE, significant reduction in MACE on these patients with the 3 months of DAPT. In other words, there was a hazard of reducing the duration of DAPT to 1 month, and bleeding was no significant difference, which is very, very interesting. In the low bleeding risk patients, we're now coming back to the 3 months, because the 12 months seems to have had no impact in MACE. There was a reduction in bleeding, and the overall one year MACE was non-inferior. So it was a non-inferiority for that MACE event. So 3 months seems to be, in the Korean patient population, seems to be the way to go. Then other Korean colleagues looked at the Smart Choice 3. This is about chronic maintenance. This was presented simultaneously, published in Lancet. Very important question. What should we do with our single antiplatelet therapy? Should it be aspirin or should it be clopidogrel monotherapy? And very, very interestingly, these investigators showed over a 3-year period of following these patients that major adverse cardiovascular events were lower in patients who received clopidogrel as their chronic maintenance, with reduction in both MI and no differences in bleeding. Very, very interesting. Similar to what we had seen a little bit at the with other Korean investigators that did the post as well. Now on to coronary and structural interventions. We finally have the CABG versus PCI, but the PCI guided with FFR guided PCI, the FAME-3 study, if you recall, the 1-year outcome had a primary endpoint that included revascularizations, and PCI was not non-inferior in that 1-year primary outcome. For this, they have 5-year data published in Lancet, presented by Bill Farron, the primary investigator. These are patients with 3-vessel disease amenable to both CABG and PCI by the heart team. FFR guided versus CABG based on the coronary angiogram for CABG, but FFR basically all of the lesions, stent all the lesions where the FFR is less than 0.8. The 5-year endpoint was now a hard endpoint of death, MI, and stroke, and revascularization was not included there. And as you could see, no difference between death, MI, or stroke all the way out to 5 years. And you see that CABG and PCI 14.1% for that MACE endpoint for CABG versus 16%. No difference whatsoever in death. No differences, a little bit more strokes, 3% versus 1.9%, but no real difference here. And MI, a little bit higher in the PCI arm, 8.2 versus 5.3. Again, important outcomes to think about. 5-year data with FAME. Importantly, once again, we see the syntax score play an important role. Once you get to the intermediate score, you start to see the benefit of CABG, and I think it just underlines the importance of a heart team approach when we're presenting these choices to our patients and how we perform our PCI. And now with imaging and physiology guided PCI, we can even do better. Speaking of imaging and physiology guided PCI, this trial by our colleagues in China from the second affiliate hospital, published in the Lancet once again, comparison of angio-derived FFR, fractional flow reserve, guided PCI versus IVUS guided PCI strategy in large numbers of patients, 1,839 that were randomized to angio-FFR versus IVUS guided PCI. And you could see that they used very important parameters with the angio-FFR as well as we were used to. And the primary outcome showed no difference at all, the P non-inferiority being similar between IVUS and FFR. And I think this is an important study, once again, to in places where you are not using intravascular ultrasound, at least a QCA-based FFR could be used at the very least to guide your PCI. Certainly, we need to do better than just angiograms. And I think this is, again, another interesting and important study for us, and we can have a discussion afterwards. We touched on this during the discussion in the last panel with the British Heart Foundation and University of Oxford doing this very, very important BHF Protect TAVI trial, a pragmatic design published in the New England Journal of Medicine with incredible number of centers and colleagues from NHS that performed this prospective randomized 7,635 patients randomized to TAVR without cerebral embolic protection versus those with. Patients were included if they were undergoing TAVR, and that the treating physician felt that the Sentinel cerebral embolic protection would be suitable for those patients. They were evaluated for the primary outcome of stroke at 72 hours after TAVR, or discharging sooner. This was mostly all of the TAVR centers in the UK. And of course, about 30% of TAVR cases were enrolled from these centers. The primary outcome of stroke was absolutely similar between the two: 82 strokes in the control arm, as opposed to 81 strokes in the cerebral embolic protection. Absolutely difference. And this is an ITT analysis. The disabling stroke, exactly the same, 53 versus 47 patients. And you see that. So no difference whatsoever. There was an important piece that about 15% of the patients in the cerebral embolic protection arm did not get the device, but their statistical analytical sensitivity analysis that they did not show the difference, taking even that into account. So I think it was an study that we await to see more of an IPD analysis between this and the other study that was done by Dr. Kapadia, and I think we'll learn more about what's going on with cerebral embolic protection. We now have the 5-year outcomes of transcatheter versus aortic valve replacement in low-risk patients with aortic stenosis. You know that we've seen the low-risk data from the SAPIEN balloon expandable valve. This is with the self-expanding Evolut valve. 5-year data presented by Dr. Reardon, presented and simultaneously published in JACC. 1,478 patients randomized in this trial with full 5-year follow-up in close to 90% of the patients in both arms. Very importantly, and if we could take you through the 24 months Evolut versus surgery, then we go into 36 months and you start to see separation of the curves still out to the 4 years in favor of the Evolut, but then we get to the 5-year data, all of the patients we see absolutely no difference, and the curves come together with a very, very similar outcome between the two. And I think what we're seeing here is that, again, TAVR in low-risk patients, similar to surgery, and I think this is very, very good news for our patients with low risk. The other very interesting trial was this new valve design, the JenaValve Trilogy heart valve system. This was in patients with high surgical risk, patients who have symptomatic severe aortic regurgitation. This is the ALIGN-AR trial presented by Dr. Makar. This is a Trilogy porcine pericardial valve, which is aligned, positioned, anchored, and deployed very, very nicely. And you could see the grasping components of this. I think there were some live cases at TIO, and I don't know, we'll talk about it. But I was very intrigued to see that the pivotal trial that had 180 patients through the FDA breakthrough technologies had the ability to enroll another 320 in continued access. This is the data on 500 patients for which we have full 30-day follow-up, and now about 400 of those with 1-year follow-up. And I think this is a very, very important study showing that they met the primary safety endpoint at 30 days with a performance goal that was about 40.5%. These were very high-risk patients, very important. But take a look at the procedural complications. No intraprocedural deaths, no rupture, no ventricular perforation, no coronary obstruction. 8 patients had valve embolization and 3 with aortic dissection. Some of those are overlapped with the valve embolization. They absolutely met that rate by having only 26.2% complication rates. A lot of this driven by permanent pacemakers, et cetera, out to 30 days. When we go to, they met when we go to 1 year, I said we have about 400 patients, and they again met this endpoint of where they needed to be. It was a 25% non-inferiority margin, and you could see here with the one-sided confidence interval up to 11.1, they came at 8.1% for their efficacy endpoint. And if you look at all-cause mortality over time, you see at 30 days, these were STS scores of 4 with 1.4%. and then all the way out to 15.5. These are high-risk patients, hemodynamic valve improvement, very little paravalvular regurgitation. I think this could be a very, very interesting technology, and we'll see how this goes, and we'll talk about it during the break. The other thing that I thought was important is this 2-year data from the triluminate pivotal trial. Saibal Kar presented this data. It was published in Circulation. You can all go there. This was 572 patients. If you remember, the primary outcome was presented by Paul Saraja, published in the New England Journal of Medicine a couple of years ago, about a year ago at ACC. I think Ajay Kirtane was the discussant. And of course, they did very well. They met their primary endpoint using a hierarchical endpoint that had a lot of patient-reported outcomes, which was how they drove the endpoint. And importantly, they had very, very good reduction of TR. Now we have 2 years, but it is important that crossover was allowed, and about many of these patients crossed over within the first 6 months. But if you see now, the recurrent heart failure hospitalization, which was a pre-specified endpoint, all the way out beyond up to 2 years and beyond, there is a reduction with the device. Understanding again that this is an ITT analysis, so therefore many of these patients within the control arm crossed over but still the device arm did better, importantly, and you see the timing of this crossover, most of these occurring within the first year. So I think what we learned, and I will just say over this quick presentation, that we are more and more moving towards enhancing our intervention with prevention and understanding better how to use some of our imaging and physiology, duration of DAPT, and now, of course, even in our TAVR with dapagliflozin with prevention of heart failure. In structural intervention, embolic protection, this is the second trial that shows no benefit, and there are many, many trials that are ongoing, 3 that I can think of that are looking at this with different devices, and it may be something to look at. The 5-year Evolut for low-risk TAVR continues to be perhaps as good as surgery, and this is very, very exciting. And this new valve for AR is exciting, and I think we're looking forward to seeing what the future will bring. This was ACC in a snap, let me tell you, and I want to thank you for including that, and I hope I did some justice to some of the top trials that is relevant to this audience. Thank you again.
Well, yeah, I got to applaud that. I mean, that was an incredible amount of data presented very succinctly with relevance. And, you know, some of the questions that were coming in from the audience were, how do you integrate these data? And is it all AI? Where does the patient fit in? I mean, that's the whole point of these meetings and trying to do recaps like this, is that you sort of try to integrate all of that together in your head and then see how you can apply it to your patients. And so I think there are a lot of lessons there, and I think you presented it in a really, really succinct way. So thanks for doing that. Holger, what are your take homes from ACC in terms of big messages, big picture? I do think I would agree with you, Roxana, what you said in the prior discussion section, that this pragmatic trial in the current iteration, how it's being done right now, it's hard to find trials where they become positive, because you lose the specificity of your effect when you sort of try to generalize it. But at the same time, we have to recognize the pressures. Holger, what do you think?
Also, BHF, UK, the BHF trial regarding the cerebral embolic protection, and it was a negative trial, as Roxana just mentioned. So all these pragmatic trials are often negative, but nevertheless, for me, it's reassuring that we, at least for the majority of patients, we do not need cerebral embolic protection in patients undergoing TAVR. And now we have 2 trials with more than 10,000 patients included, which is for me a relatively clear sign that you probably will not need it, except for maybe valve-in-valve procedures where you are using basilica techniques. This is where we still use it, but we do not use it in clinical routine anymore. I think this is a very important message.
You know, one thing that's important about that, Go ahead, keep going.
Yeah. Another important message for me was also looking for the T-tier procedure, looking after 2 years, that there is a reduction in heart failure hospitalization. I think this is important because for patient inclusion or the patient's characteristics, it was a relatively low risk trial. And I think this is also important to see that at longer follow-up, nevertheless, many of these patients have a benefit from T-tier. I think this is important, but there are many ongoing trials. I know one trial also, which is currently performed in Germany, where we try to enrich the risk of the patients because these patients have higher risk of or at higher rates of previous congestive heart failure hospitalization. And I think this is very important to show really a benefit by these procedures or by these interventions.
No, thanks, Holger. You know, just back on the embolic protection thing, it's a little curious to me in the sense, and maybe I'll ask Mike and Roxana what your thoughts are. But remember, it's a new device in the UK. The proctoring part, which is real for this device, was, you know, probably not as well enforced within the trial. And CT scans, which are done routinely in our practice and others for screening to make sure that there's no carotid disease and that sort of thing, were not done routinely or looked at that way. So maybe Mike and Roxana, I'll tell you what I think. If I were going for a TAVR and I had a CT scan showing that my carotid subclavian anatomy was fine, and I was doing it at a site, which I was going to do, that was pretty facile on the use of this device, Mike and Roxana, would you say, no, we don't want to use this device because, you know, the data is negative? I'm voting for the device for myself. I don't know what you both think.
Yeah, I want the seatbelts on, so I want it on. Yeah, I mean, I think I want to make sure that I'm in a site that is very used to using these devices and has done a very good job in evaluating my anatomy and my arch and feels comfortable in placing those. And then, of course, I would want it. Yes.
Mike, what are your thoughts? You can be the arbitrator here. It's a one.
Yeah, I agree with your thoughts. I mean, it's interesting having gone to the FDA to discuss designs for antithrombotics and looking at CT and MRI related strokes rather than clinically significant ones. The FDA pushed back very strongly and said, we don't know what, quote, Swiss cheese in your brain means. I don't want Swiss cheese. I really want a nice piece of, you know, cheese up there that doesn't have any holes in it. So I would vote for having the device.
But maybe we need newer devices that are more easily applicable and that sort of thing. So let's go there. You know, I think we're about to go to live cases. I think.
Yeah, but I wanted to just say one point, if I could make one point. I think one of the biggest things that we talked about with regard to implementation science is all of us understanding that physicians, it takes them a very, very long time to digest the data and then think about which patient they're going to use the new data. And they're very resistant to change. I mean, we now have class 1 indication for P2Y12 monotherapy. If you look in the NCDR and in all of the clinical trials that we're looking at, everyone is still on DAP 2 years after their stents. Because if the patient is doing well, the doctor is going to be very worried about withdrawing and it's working. I'll leave it alone. You know, I'm not changing. So implementation science is extremely difficult to deploy amongst physicians who get used to a certain way of treating their patients. And if it's going well for them, they're not going to change it, whether it's evidence-based or not.
That's a super important point, and I think let's cap it off there, and hopefully we'll be able to talk about implementation during the live cases as well. But this is so important, and hopefully, Roxana, I mean, we didn't mention you're going to be either vice president of the ACC, you're going to be president next year, but this is also an area that's really important for clinicians, and you'll actually move the needle if you can get physicians to implement what therapies have been proven to be efficacious. So I think that's super important. Let's now move on. Mike, absolute pleasure having you.
We need implementation science to overcome the inertia science.
That's right. True pleasure having you. Thanks for joining us today. And let's go on to the live cases.